So this is the fifth episode of the first season, and today we are going to discuss about the properties and interpretation of the normal ECG. As usual, I'll be presenting a few multiple choice questions to you, and there will also be some problems coming over as we keep discussing the interpretation of the ECG strip. So let us start with the first question, and I'll encourage all of you to answer so that constantly keep getting feedbacks. So this is your first question. The printed record of the ECG is called electrocardiogram, electrocardiograph, electrocardiography, or none of the above. Next question. Electrical activity of the heart can be recorded from the body surface. What is this property of body called? Next question. The last part of the heart to depolarize is. So which part of the heart depolarizes last? Okay, so let us review the origin and spread of the cardiac impulse and how the ECG gets generated from that. ECG or electrocardiogram refers to the electrical recordings of the different events in the cardiac cycle. Now, there are three very closely related terminologies. When ECG ends with the suffix gram, it refers to the printed record. When it ends with graph, it refers to the recording machine. And when it ends with graphy, it refers to the procedure. So an easy way we always say for the students to remember is that the graph paper is not called graph. So the printed record is electrocardiogram. The machine which records the electrocardiogram is called electrocardiograph. And the procedure of recording the ECG is called electrocardiography. Now, for recording the electrical activities of the heart, we really do not dissect the body and reach out to the heart. We place the electrodes on the surface of the body. And although we place it on the surface of the body, the electrical activities of the heart can be well recorded. This is because our body is full of electrolytes. And the electrolyte solution, that is tissue fluid and blood, are very good conductors. So the whole body volume behaves as a conductor. So the property that enables us to record the ECG from body surface is volume conduction. And that is why the human body is also known as a volume conductor. So a conductor where a charge or potential generated at any part in the depth of the body can be recorded from the surface with some degree of precision. So this is the property of a volume conductor. The body is a volume conductor because of the presence of electrolyte solutions all over the body. So how does the electrical activity of the heart start? In the first episode of this season, we have discussed the properties of the cardiac muscle, and we have understood how electrical impulses generate through pacemaker potential. Today we will discuss the direction of spread and the steps of spread of that electrical potential. Now, under normal circumstances, the pacemaker of the heart is the sinoatrial node. Once the impulse generates at the sinoatrial node, current flows through the three internodal tracts to the AV node. Simultaneously, current also flows through a branch of the anterior internodal tract, which is also known as the intraatrial pathway, so that the left atrium and the right atrium simultaneously contract. Now, after the current reaches the AV node, the current waits here for some time. This waiting period is known as the nodal delay. This is caused by lack of sufficient number of gap junctions in the AV node cells. This nodal delay is physiologically important, as we have seen before also. It allows the ventricle to fill properly before getting depolarized and then contract. After the nodal delay, the current escapes into the common bundle of His and then divides into the left bundle and into the right bundle. The left bundle further divides into an anterior fascicle and a posterior fascicle. Finally, they terminate into finer conducting fibers known as the Purkinje cells or the Purkinje fibers. And in this way, the electricity passes throughout the heart. Now, if we want to see the instantaneous electrical vectors or the compounded electrical vectors that are generated during this process, let us start the whole calculation once more. So let's assume that in this schematic diagram, we are showing cut section of a heart within the junctional tissue. So before we start discussing about vectors, let us first address this fundamental question: what is a cardiac vector? So from our knowledge of elementary physics, we all know what is a vector. A vector is essentially a physical quantity which has a magnitude and a direction. So it is essentially a vector quantity. And here we are talking of the flow of electricity. So the cardiac vector is an electrical vector. Whenever current flows from one part of the heart to another, all the instantaneous flow can be averaged or algebraically summated into a resultant vector. And this helps us understand the direction of flow of the current and also interpret the ECG. Let us therefore understand what are the prominent vectors that are used by the electrophysiologists for analysis of the ECG. When current is first generated in the heart, from SA node, the current moves towards the AV node. So this is the first current that is generated. And this, if I label this as P, because it represents the P wave, we will see that later, the P vector represents the atrial depolarization vector. So the current initially, the summation of all the currents initially is directed more towards the left. So it is directed towards the left and downwards. So although there are individual currents passing through the internodal tracts, the summated vector looks somewhat like this. This is the first average vector that is noticed in the electrocardiogram. Then the current will reach the bundle of His. So as the ventricle starts getting depolarized, because the left bundle branch is much thicker, the left bundle branch receives the current first, because you know that the thicker a fiber is, lesser is the resistance. So as the left side of the septum becomes positive, automatically the right side being at the resting membrane potential, which is negative, so automatically current flows from higher potential to lower potential, and therefore the next vector moves from left to right. And this vector can be called the septal vector. I am using the letter Q for this. So the Q vector is the septal depolarization vector. And under normal circumstances, the septum depolarizes from left to right because the left side gets depolarized first. Thereafter, the current flows downwards towards the apex. The current will flow downwards towards the apex. And after moving to the apex, this vector does not have a name, so we can simply call it the second ventricular vector. So Q vector is the first ventricular vector, and the second ventricular vector shows how current moves to the apex of the heart. After moving to the apex, now current moves simultaneously into the left ventricle and also the right ventricle. As they are happening simultaneously, so a resultant vector is observed by the electrodes. Now, both of them are pretty big vectors. So, left-sided vector may be represented as something like this, right-sided vector like this. You can see that I have drawn the left-sided vector longer. This is because the left ventricle has greater muscle mass, and therefore the bulk of current flowing through it is more than that of the right side. But since they are never measured separately under normal condition, they happen simultaneously. So simply by using the parallelogram law of vector summation, you can understand that there will be a resultant vector, and the resultant vector will be tilted more to the left side because of the greater magnitude of the left vector. And this is the mean ventricular vector. This mean ventricular vector also determines to a large extent the axis of the heart, by which we mean direction of this mean vector. So we have the mean ventricular vector that represents depolarization of the ventricles. After the whole ventricle is depolarized, a small amount of current now depolarizes the part which was not yet depolarized. And this small vector will be moving upwards towards the posterobasal part of the left ventricle. And therefore, the last vector, that is the final ventricular vector, represents the upward depolarization of remaining ventricular tissue. So what are the last part of the heart to be depolarized? The last part of the heart to be depolarized simultaneously are the posterobasal part of left ventricle, the upper part of interventricular septum, and the pulmonary conus. These are the last parts that are depolarized, and they happen simultaneously. So again, I'm repeating this whole thing. So in summary, at first the atrium depolarizes, generating the P vector. Then the current waits at the AV node, enters the bundle of His. Then the septum will depolarize from left to right, and this is represented by the Q vector. The second ventricular vector represents the flow of current downwards towards the apex. Then the mean ventricular vector represents the combined depolarization of the left ventricle and the right ventricle. And the final ventricular vector moves upward depolarizing the posterobasal part of the left ventricle, upper part of the interventricular septum, and the pulmonary conus. So these are the major average electrical vectors that depolarize the heart. Is this clear to everyone? Then I'll proceed to the next portion. Please write yes if you have understood. Okay. So, yes, I'll repeat the final ventricular vector. Final ventricular vector is nothing but the part of the heart that is near the junction of the atrium and the ventricle. That part is depolarized last because current is moving from below upward in the ventricles. So the base of the heart, so to say, depolarizes last. This includes the posterior and basal part of the left ventricle, the exact upper and posterior part of the interventricular septum, and the pulmonary conus. The pulmonary conus is the part that gradually narrows down and gives rise to the pulmonary artery. So I hope this is clear to everyone. So this is again a diagrammatic representation of what I was just now saying. So see, uh, at first after the P vector, now there is a ventricular vector. The first ventricular vector is the septal depolarization from left to right. The second vector is directed downwards towards the apex of the heart. The third one is the mean vector of right and left ventricle. It's directed more towards the left because the left vector is relatively longer. And the final one is directed upwards towards the posterobasal part of the left ventricle. So these are the four major average ventricular vectors. So how does it relate to the ECG? What is the importance of knowing these vectors and how does it relate to the recording that we get in the ECG? The concept is very clear. If you place an electrode in any part of the body, the electrode will be definitely making some angle with the heart. So if this is an electrode, suppose this lead 1 represents the axis of the electrode and the actual vector that is passing through is represented by the vector A. Now, if A makes an angle of suppose x with the axis of the lead, then obviously the recording on the lead will be x A cos x. So A cos x, that is A cos theta, will be the component of that vector on the axis. Which means when a vector is generated, if we look at the heart from different angles, every angle will get a specific magnitude. That is the cosine component of that vector. If by chance my looking angle is 90 degree to the vector, I will see nothing because cos 90 will be 0. So this is how the different electrodes pick up different components of the vector, giving us the view of the electrical activity from various angles of the heart. And we can also algebraically, that is in a very mechanistic way, sum them up using the vector analysis curves and then find out the actual vector that was operating inside the heart. So this is known as the uh, Cartesian system of the heart. So to understand how to calculate angles, the x-axis is taken as 0 degree. Taking the x-axis, that's a convention. After taking the x-axis as 0 degree, clockwise and anti-clockwise, the angles are arranged. And the different leads that look at the heart from various angles, they are given different names. As you can see, each of them have an angular disposition. For example, lead 1 is at 0 degree. Lead AVF is at 90 degree. We always measure the angle from the positive end of the lead. AVL is at minus 30 degree. Lead 2 is at 60 degree. So likewise, the Various leads look at the heart in the vertical plane from various angles, and these angles help us understand what is going on inside the heart, as we shall see later. After the recording, when we look at the normal ECG, the normal ECG looks like this. It has a few positive waves which are upward deflection, some negative waves which are downward deflection. And the durations are known as either segment or interval. When the duration does not contain any wave, it is called a segment. And when the duration includes at least one wave, it is known as an interval. So a segment does not contain a wave, whereas interval contains a wave. That is the basic difference between segment and interval. So what are the different parts of the ECG? Let us see. And what are their properties? So we will go one by one through the different parts of the ECG. The waves of the ECG are named as PQRST. That is also by convention, because when Sir William Einthoven published his work, he simply used geometrical nomenclature system. So this could have been ABCDE. It was just written as PQRST, and those became conventions. There is no special reason for calling it PQRST. So what does the first positive wave, P wave, represent? The P wave represents, as we all know, atrial depolarization. So when the atrium depolarizes and the P vector is generated, it causes an upward deflection. This is known as the P wave. How do we know that the P wave is normal? You know that the ECG is placed on a graph paper that is graduated in millimeters. So the normal P wave will be, if I go by the properties, the criteria for a normal P wave are that the P wave measures less than 3 millimeter in height and less than 2.5 millimeter in width. So a normal P wave measures less than 3 millimeter in height and less than 2.5 millimeter in width. The second criteria is that all P waves in the same person look similar, look alike. Thirdly, if the heart is working properly, one P wave will be followed by one QRS complex. So if these criteria are met, then probably we are dealing with a normal P wave. So P wave represents atrial depolarization. It measures less than 3 millimeter in height and less than 2.5 millimeter in width. All P waves in a same person should look alike in the same lead, and one P wave is followed by one QRS complex. We now go into the QRS complex. So what are the common properties of QRS complex? Remember, in all leads, all the waves of QRS may not be present. You may get only Q and R, you can only get R and S. So that is also absolutely okay. But whatever be the configuration of the QRS complex, if you try to find out the duration of the QRS complex, the duration of the QRS complex should be less than 3 millimeter. So the duration of QRS complex sorry, should be less than 3 millimeter. That is the only important criteria that we should remember. There are also other criteria, but that is not within the scope of today's webinar. So the duration should be less than 3 millimeter. When the duration is less than 3 millimeter, it is called narrow QRS complex. Although it is called narrow QRS complex, this is the description of the normal QRS. If it is more than 3 millimeter, it is called wide QRS, but that is abnormal. So narrow QRS complex is the normal QRS complex. Now we can discuss about the distance between the beginning of the P wave to the beginning of the Q wave. This is known as the PQ interval. Sometime when Q wave is not seen, so it is commonly called PR interval. So what does the PR interval represent? See, we have already seen that P wave represents atrial depolarization and QRS complex represents ventricular depolarization. So the time between the two, what does it indicate? From the beginning of atrial depolarization to just the beginning of the ventricular depolarization. Now the beginning of atrial depolarization occurs at the SA node, and we have seen that the first vector that originates in the ventricle is the septal vector. That means during the PR interval, the current flows from SA node to the end of bundle of His. Just after that, the septum starts. It is a very common misconception that it is the current flow from SA node to AV node. It is not from SA node to AV node. It includes the AV node. It is from SA node to AV node to the bundle of His, and that duration is known as the PR interval, after which the Q vector or the septal vector will start. So if there is any abnormality in this pathway, the PR interval will become prolonged. The common cause of abnormality usually lies in the AV node. So in AV nodal blocks, we get elevated PR interval. So what is the normal duration of the PR interval? Normally it should be between 3 to 5 millimeter. Now in the x-axis, 1 millimeter, we shall see later also, stands for 0.04 second. Therefore, 3 to 5 millimeter translates into 0.12 to 0.20 second. That is the normal PR interval, time taken for current to flow from SA node to the bundle of His. The next important finding in the ECG is the T wave. So what does the T wave represent? The T wave represents ventricular repolarization. Now, there is a very common paradox that can come to your mind. See, the depolarization wave is directed upward, which is a positive current. Repolarization, which is a negative current, is also directed upward. So it seems quite paradoxical. We could have thought that the T wave should be inverted because it is a negative wave. So can someone explain in the chat box why, despite being a negative wave, the T wave is upright? If the QRS is upright, then the T wave is supposed to be downward, but it is still upward. Why is it still upward? Amruta, you are saying it measures the current, not the direction. No, not at all, because these are vectors. A vector represents direction as well. Of course, the vector is in that direction, but why? No, it's also not because it's directed to the negative electrode. Very good. So Dhwani is saying that because the direction of depolarization and repolarization are opposite. And that is exactly the answer. So I'll tell you exactly what happens here. So if this is a schematic representation of the ventricle, and if these are the ventricular muscles, when depolarization occurs, I'm representing depolarization with the black color. When depolarization occurs, current moves in this direction. And this is a positive current. So obviously, the recording electrode, which is facing this side, will record an upward deflection. That is why the QRS complex is upward. Now what happens for the repolarization is, repolarization occurs from the epicardium towards the endocardium in the opposite direction. So, and this is the negative current. So a negative current in one direction is equivalent to a positive current in the opposite direction. So this can be mathematically represented as this. So because the direction of depolarization and repolarization are opposite, that is why it also gets picked up as a positive wave and the T wave becomes positive. There is also another interesting way of looking at it. I told you that repolarization occurs from the surface towards the inside. So when the surface is repolarized, it has become negative. But the inside has not yet become negative. It is still positive. At this point, as current flows from positive to negative, the instantaneous vector is directed outward, which will also be picked up by the electrode, and therefore a positive upward deflection will form. So in whichever way you discuss, the basic reason is that the direction of depolarization and repolarization are opposite. Their charges are also opposite. So minus and minus makes it plus. So a negative charge in opposite direction is same as positive charge in the same direction. Is it clear to everyone? Okay. So what are the properties or attributes of a normal T wave? In a normal T wave, it is usually upright. By upright, we mean in the same direction as the P wave or the depolarization vector of the atrium. Also, its height normally does not exceed 10 millimeter. Of course, it varies from lead to lead, but it never exceeds 10 millimeter. If it exceeds 10 millimeter, then it can be called a tall T wave, which can be seen in some disorders like high level of potassium in the body. So these are the properties of a normal T wave. Now let us come to the gap between the time interval between QRS complex and the beginning of the T wave. You can see that in this gap, there is no wave. Therefore, it can be called a segment. And therefore, this is known as the ST segment. It is not called interval because it does not contain a wave. The length of the ST segment is not important. What is important is its position. Is it elevated upward, which is called ST elevation, or is it depressed downward, which is called ST depression? Normal finding is it should be a flat line. So ST segment is isoelectric, which means it is flat. So how do we know this is flat? What is the line for comparison? The line for comparison is the line between the T wave and the next P wave. This is the standard line of the ECG, and this is known as the TP segment. So if the TP segment and the ST segment are at the same level, then we say ST segment is isoelectric. If the ST segment is much above the TP segment, it is ST segment elevation. And if the ST segment is much below the TP segment, then it is called ST segment depression. TP segment is always taken as the zero position or the standard position. Now, why is the ST segment isoelectric? Why is it flat normally? The reason is very simple. You can see it is the gap between QRS and T. QRS complex represents ventricular depolarization. So QRS complex represents depolarization of the ventricle. T wave represents ventricular repolarization. So what is happening in the ST segment? The depolarization is just complete. but repolarization has not yet started. So if depolarization is complete, then the whole of the heart is depolarized. And repolarization has not yet started. So the whole heart is at the same electrical potential. If they are at the same electrical potential, there is no potential difference between any 2 points. And if there is no potential difference, there is no flow of current. So the electrode does not find any current flowing. And that is why there is no upward or downward deflection. So during the ST segment, the whole ventricle is depolarized. Electrical potential all over the ventricle are same. So there is no potential difference. As there is no potential difference, there is no flow of current. As there is no flow of current, the line becomes isoelectric, neither deflected upwards nor deflected downwards. That is why the ST segment normally should be isoelectric. Is this clear to everyone? Very good. So now we come to another very important determinant, that is from the beginning of the QRS to the end of the T wave. And this is known as the QT interval. It is called interval because it contains so many waves. So what does the QT interval represent? Why is it important to know about the QT interval? The QT interval, you can see, it represents the entire depolarization and repolarization of the ventricle. So we can simply say it represents the time taken for entire electrical activity of ventricle. So all electrical activities of the ventricle happen in the QT interval, which means if there is any defect in conduction of electricity, then the QT interval will become prolonged. The problem can lie in the bundle branches, problem can lie in the myocardium, problem can lie in the Purkinje fibers. So problem can lie anywhere. But whenever there is a delay in conduction of electricity in the ventricle, this will cause QT interval prolongation. Normal QT interval is less than 0.43 second, which in terms of millimeter will become less than 11 millimeter. When it is more than this, we say that the QT interval is prolonged. We shall see later that QT interval can also be corrected to a certain extent, which is called corrected QT or QTC. And that concept is very important for understanding arrhythmias. So I will discuss that later. So up to this, is this clear to everyone? The P wave, the QRS complex, the T wave, the PR interval, the QT interval, and the ST segment. These are the basic essentials we should know to interpret the ECG. So is it clear to everyone? Okay. So see, these are the surface electrodes that are attached to different parts of the body. So when we talk about leads, try to answer this question. What does lead in the ECG refer to? Okay, we'll come back to this answer. Uh, Next one is inferior wall of the heart is represented by? Next question. On a standard ECG, which one is true? So let us discuss about the various electrodes. Electrodes are placed at different parts of the chest wall and also on the limbs. The potential difference between the electrodes is known as lead. So lead is not what you attach on the body. What you attach on the body is electrode, and the difference of potential between any two electrode is known as the lead. Now, these leads can be placed in different manners. So if you name the different leads that are measured or seen in the standard ECG, there are three standard bipolar limb leads, and these are named as lead 1, lead 2, lead 3. There are three augmented limb leads named as AV, R, AV, L, and AVF. And there are six unipolar chest leads. They are named as V1 starting from the right side to V6 ending on the left side. So altogether, if you see, total number of leads that we have are 12. That is why the common ECG is also known as a 12 lead ECG. So this diagram shows the placement of the chest leads. V1 is on the right side, V2 is on the left side of the sternum, the V4 is at the mid clavicular line, and V6 on the anterior axillary line, and then V3 and V5 are just placed in between them. I will come to these individual leads and the significances that they have. I told you that it is important to look at leads as something looking at the heart. So let us try to understand which part of the heart is looked upon by which lead. For your simplicity, I will draw a schematic heart here. So suppose the heart is placed here. And this is the interventricular septum. So under this situation, it is very easily understood that the lead V1 will look at the right side of the heart. Both V1 and V2 can look at the septum of the heart. V3 and V4 look at the anterior surface of the heart. V5 and V6 look at the left side or the anterolateral side of the heart. So I am repeating, just look at the heart and you can easily understand. So V1 looks at the right part of the heart. V2 and V1 both are looking at the septum. V3 and V4 are looking at the front surface, that is the anterior part of the heart. And V5 and V6 are towards the axilla, so they are looking at the left ventricle or the left lateral wall of the heart. So information about different parts of the heart can be obtained from these different leads. This is only about the chest lead. I will also talk about the limb leads. So is this clear to everyone? Okay. Let us now talk about the standard limb leads and the augmented limb leads. Now see, here again we can draw a schematic heart and try to understand what they are looking at. Suppose this is a heart. And the plus end are where the eyes of the lead are. They are looking at the heart from there. So see, it's very easy to understand. It is quite understandable from this diagram that lead 2, 3 and AVF are looking at the bottom part of the heart. That is the inferior wall. So 2, 3 and AVF look at the inferior wall of the heart. Lead 1 and AVL look at the left ventricle. That is the left lateral part or anterolateral part of the heart. AVR is on the right shoulder. So what AVR is looking at is how the electricity is going away. So AVR looks at the heart from the top. And here again, if we remember what we have already discussed, V1 looks at the right part of the heart. Both V1 and V2 look at the septum of the heart. V3 and V4 they look at the anterior wall of the heart, and V5 and V6 look at the left lateral wall of the heart. Is it clear to everyone? Okay. So we can summarize this by saying that the septal leads are V1, V2, anterior leads are V3, V4, lateral or the left lateral surface can be seen by lead 1 and AVL, also by V5 and V6. Inferior wall can be seen by lead 2, 3 and AVF, right ventricle by V1. Right at this point, you don't have to bother about the V4R. So V1 is the right ventricular lead. So this is a very easy way of understanding the direction of the lead without memorizing it. You simply draw a heart at the middle of the Cartesian system and you will easily understand in which direction which lead is looking. The ECG paper is calibrated in such a way that each millimeter in the x-axis represents 0.04 second and each millimeter in the y-axis represent zero point 0.1 millivolt. This is how the standard 12 lead ECG looks like with the 12 leads printed. Lead 2 is taken as a long recording for recording of the rate and rhythm. So it is also sometimes known as rhythm strip or the long lead 2. So getting back to the questions that we started with, let us start. The printed record of an ECG is called, what will be the answer? Very good. The answer is A, electrocardiogram. Next question. Which property of the body enables recording of the electrical activity? Wonderful. The property of volume conduction. What is the last part of the heart to depolarize? Very good. All of the above. What does a lead in ECG refer to? Wonderful. The potential difference between the electrodes. Inferior wall of the heart is represented by what? Very good. Leads 2, 3 and AVF. On a standard ECG, which one is true? Very good. Both of the above. So now we will go into the steps of interpretation of a 12 lead ECG. So what are the different steps to interpret a 12 lead ECG? You first find out the rate, the rhythm, then comment on the P wave, the duration of the PR interval, the duration of the QRS complex. Then mention whether the ST segment is isoelectric, comment on the T wave, the QT interval, and then I'll discuss how to find out the cardiac axis. And combining these 9 points, he will give you an impression whether it is a normal ECG or it is an abnormal ECG. Today we are discussing the normal ECG. So let us start with calculation of the first 5 points, which is also known as rhythm strip analysis. So when an ECG strip is given to you and you have to find the rate and rhythm, what are the ways to do that? In rhythm analysis, step 1 is to calculate the rate, step 2 to comment on the regularity, step 3 to assess the P waves, step 4 to determine the PR interval, and step 5 to determine the QRS duration. With this, almost all of the different kinds of arrhythmias can be diagnosed. So how do you calculate rate? To calculate rate, you find out the number of small square between the two R waves. This is called RR interval. And then divide 1500 by that number. So you can see here that if I count the number, for simplicity, choose a point where it is coinciding with a line. So this is the RR interval. Each big box is 5. So you have 5, 5, 5, 15, and the other one 16, and then there is a little bit more. You can either take it as 16 or you can take it as 17. Whatever you do, you approximate to the nearest whole number. So suppose I am taking it as 16. So 1500 divided by 16 is 94. Therefore, the average heart rate is 94 beats per minute. So it's a very simple method. Count the number of small boxes between two R waves, divide 1500 by that number. What you get is the heart rate per minute. The second step is to find out the regularity. You look at the RR intervals. If the RR intervals are all equal, that means we are dealing with a regular rhythm. If the RR intervals are not equal, then it is an irregular rhythm. In this case, the RR intervals are all equal and therefore this can be called a regular rhythm. Third step is QRS duration, or before that the P wave assessment. Now we know what to look for P wave. First you see whether there are P waves. Yes, there are P waves. We have all marked them. Do all P waves look similar? The answer is yes. You can look at the P waves and they all look similar. Do all the P waves occur at regular rate? Yes, almost at regular interval they are coming. Are the dimensions normal? Let us measure. Upward it is about 1 box and horizontally it is about 1.5 box. We know that it has to be between 3 boxes upward and between 2.5 boxes horizontally. So yes, it is normal. Is there one P wave before each QRS? Yes, PQRS, PQRS, PQRS. There is no exception. So all points are met and therefore these are normal P waves with one P wave for every one QRS. Next, the PR interval. PR interval is from the beginning of the P wave to the beginning of the QRS complex. It can also be called PQ interval. Now, normally it is 0.12 to 0.20 second. Let's see what is found here. The gap is about 4 boxes. So 4 boxes means 4 into 0.4, that is 0.16 second. That is well within the normal range. So the PR interval is normal. Next comes the QRS duration. That is from the beginning of Q to the end of S. So as I can find here, it's about 2 boxes, slightly more than 2 boxes. You can either take it as 2 boxes or 3 boxes. Normally it should be less than 0.12 second or less than 3 millimeter. Here I think I will take it as 2 millimeter. Even if you take it as 3 millimeter, it is still normal. So it is not exceeding 0.12 second. And therefore this is a normal QRS duration or narrow QRS complex. So in summary, the rate is found to be around 94. Regularity is present. P waves are normal. PR interval is 0.16 second, which is normal. QRS duration is 0.08 second, which is normal. So interpretation is it's a normal sinus rhythm. So this is how step by step a rhythm analysis can be done. Is it clear to everyone? So now I will be giving you a few problems. You comment on the rate and rhythm. You can use calculators, divide 1500 by the RR interval to find out the rate, and just look at the spacing between the R wave to comment whether they are regular or irregular. So this is your first question. So look at this ECG strip and find out the rate and rhythm. You know that the rate can be found out by dividing 1500 by the RR interval. To help you, I'm marking the RR interval. You can start with any of them. To count rapidly, count each large box as 5 and then count the smaller boxes on the side. That is the easy way of counting. So what is the RR interval here? So you can see that the RR interval is about 1, 2, 3, 4, 5, 6, 7, 35, 6, 7, 8, 9, 40, 41, 42, about 43. So we can write the rate as something like 1500 divided by 43. And when you divide 1500 by 43, you get around 35. So the rate will be around 35 per minute. So 35 to 36 per minute. And you can see that the RR intervals are equal, therefore the rhythm is regular. Very good. So this is definitely a case of bradycardia. The normal heart rate is between 60 to 100. So this is a case of bradycardia. So you can easily count 43 like this. Each box that you see here is 5. So we have 7 such boxes, that is 35. Then you count the small boxes. 36, 37, 38, 39. And here it's 40, 41, 42, 43. So I hope this is clear to everyone. You are just counting how many millimeters are there between the two R waves. So we'll move on to the next question. Calculate the rate and rhythm. Same method. So try. This is the RR interval. So rate is equal to 1500 divided by the RR interval. That is 1500 divided by. So count the RR interval. The RR interval is 1, 2, 3, 4 boxes and a few more. That is 20, about 22. So if this is 22 or 23, whatever you take, uh, then the value comes to around 69 per minute. Individual calculation can slightly vary because of the observation, because someone instead of taking 22 can take 21. So automatically if you take 21, your value will be 71. It doesn't matter as long as it is within the normal range. And rhythm is definitely regular, that is visually seen that it is coming at equal intervals. So up to this, is this clear to everyone? How to find the rate and rhythm? Okay. Can you calculate the heart rate here? This is the RR interval. Yes, it will come to something around 100 or slightly more than 100, because you have about 10 boxes, slightly less than 15, like 13 boxes. So if you divide 1500 by 13, you get something around 115. Yes. So the heart rate is around 115 per minute and it's regular. So this is an example of tachycardia. Can you comment on the heart rate and rhythm here? The heart rate rhythm is definitely irregular. So how do you find out the rate in presence of an irregular rhythm? There are different ways of doing that. There are various ways of reporting this. I find one method to be easy. So you take a longer distance like this from one R wave to a number of R waves apart and see how many small boxes are there. So I'll count by 5. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24. And then the extra box, 24 means it's 24 into 5. That is 120. And then you have 1, 2, 3, 4 extra. So it's 124 boxes. 124 boxes are present between how many RR intervals? 1, 2, 3, 4, 5, 6, 7, 8. So as a rough calculation, you divide the total number of boxes, that is 124, by the number of RR intervals, 8. That means the average RR interval is 124 by 8. So for 8 RR intervals, we have about 124 boxes or millimeter. So average RR interval is 124 by 8. That comes to something around 16. So now the calculation becomes easy. So no, you don't count the number of R waves. You count the number of intervals. Each interval is a cardiac cycle. So if you divide 1500 by 16, by 15 it will be 100, and if you divide by 16 it comes to around 93. So that means the average heart rate, it is not the actual heart rate, the average heart rate is about 93 or 100 per minute. So this is one way of reporting that. There are also many other ways of reporting. You can find out the uh, shortest interval and the longest interval, and then comment that the heart rate varies between this and this. That is also another way of reporting the same. So I hope this is clear how we find out the average heart rate. Now QT interval, I told you, it's from the beginning of the Q wave to the end of the T wave, and it represents all the electrical activities that are going on in the heart, in the ventricle. When there is a confusion as to where you should stop, you take the slope of the T wave, and where it cuts the straight line, horizontal line, that is the point up to which QT should be measured. I told you about corrected QT. So one way of correcting the QT is that the QT interval is divided by root over RR interval. This adjusts the QT for a standardized heart rate. I will explain that later. And by this method, you can find out the corrected QT or QTC. So before I go into the discussion, what is your idea about QTC? Let me see. What does QTC represent? Read the 4 points and you say, what do you think? What is a corrected QT? Okay, so let me answer this. Actually, when we talk about corrected QT interval, it is a mathematical way of expressing the QT if the heart rate would have been 60 beat per minute. It is not that we need this calculation every time, but for very sensitive assessment of QT interval and also for research purposes, QTC is a very important calculation. All the formulas that are proposed by different electrophysiologists, they are based on rigorous observation and integral calculus. That is again beyond the scope of today's webinar. What I'm trying to say is there is no single formula for that. But the most popular formula is the Bézet formula, which I have used in the previous example. You divide QT interval by the root over RR. And this gives you an idea that if the heart rate would remain at 60 beat per minute, what will be the QT? Now you may ask, what is the importance of doing this? As with the heart rate, the cardiac cycle duration changes, so QT interval also changes. So if I say that this person has a long QT, not because there is a problem, but because he has a bradycardia. The other person has a short QT, not because he has a problem, because that person has a tachycardia. So everything is less. So how are you going to justify your point? You will say, okay, let me convert that heart rate into such a mathematical form that the heart rate is converted into 60 beat per minute. And then let me compare the QT of the two people side by side. This is exactly what QTC does. So in very sensitive calculation of the QT interval, when the heart rates are at the extremes, QTC is actually a very important calculation. It is okay if you don't understand this when you are in the first and the second year, and with time you will understand the importance of QTC. Now comes the most interesting part, the cardiac axis. What does the cardiac axis mean? The cardiac axis means the direction of the mean cardiac vector or the mean ventricular vector. So how do you find out the cardiac axis? We have already seen that there is a standard Cartesian system of the heart. And normally the mean ventricular vector lies somewhere in this direction. So the average ventricular vector in a normal person is usually plus 59 degrees. That doesn't mean that every one of us will have the same value of the ventricular vector. The ventricular vector can lie anywhere between minus 30 degree to plus 110 degree. So between minus 30 to plus 110, any value of cardiac axis is considered to be normal. If the cardiac axis goes beyond the minus 30 degree, it is called left axis deviation. If it goes beyond 110 degree, it is called right axis deviation. And you can easily understand that this quadrant is a very funny quadrant. Left axis deviation and right axis deviation both can come here. So sometimes this is known as extreme axis deviation. So when we are looking at the ECG, how can we comment on the axis and understand whether the cardiac axis is normal? I'll teach you three methods to do that. A very standard method that is written in textbooks, a shortcut method that we use in the ICU and clinical setting, and the third method is something that I like to teach my students because it is easy at the same time most accurate method. So let us see how the cardiac axis can be found out. Now the standard method that is taught in the textbooks is like this. The placement of the lead is shown by the Einthoven triangle. So you simply draw an isosceles triangle on a white piece of paper. Then you open the ECG strip. How do you calculate the value of the QRS vector? You calculate the upward deflection, and if there is a downward deflection, you also calculate that. You subtract the upward and downward and you get the net vector. So here it is 5 millimeter on top, 0 millimeter below. So the magnitude of the vector is plus 5 millimeter. So you plot this along lead 1 as a 5 millimeter plotting. So it should be a graph paper and 5 millimeter should be drawn here. Similarly, in lead 3, this is the axis of the lead 3. Suppose you are getting plus 11 on top and minus 1 below. So the net vector is 10 millimeter. So you plot 10 millimeter here. It is sufficient to plot any two. It's not necessary to plot all the three. Because if we get two components, you can easily get the vector. Then simply draw perpendiculars from the vector. The point where the perpendiculars meet give you the mean vector with magnitude and direction. So this is the simplest way of finding out the vector. But I find this method a bit cumbersome. So I'll teach you a simpler method by which you can just look at the ECG and tell the value of the vector. Let's try that also. If you look at the Cartesian system of the heart, what is interesting is lead 1 and lead AVF are at right angles to each other. Because they are at right angle, they don't influence each other. There is no component of 1 on AVF, no component of AVF on 1. So we can use this knowledge for the axis. For simplicity, let's think any axis between 0 to 90 is normal. Any axis in the 0 to minus 90 may be left axis deviation. I am saying maybe because the minus 30 is included here. Any axis between plus 90 and 180 may be right axis deviation. I'm saying maybe because plus 110 is included here. And any axis between minus 90 to plus 180 is extreme axis deviation. So you simply look at the QRS vector in lead 1 and AVF. If both are positive, then their resultant lie in the first quadrant. That's a normal axis. If lead 1 is positive but lead 2 is negative, then the resultant lies in the upper quadrant, the right upper quadrant. There is a possible left axis deviation unless this is 30 degree. If the lead 1 is negative and lead AVF is positive, it lies in the lower left quadrant. And therefore, there is a chance of right axis deviation. And if both are negative, you are dealing with an extreme axis deviation. This is a visual way of interpreting, but again, this is not very accurate. But still, is this clear to everyone? Then I will teach you the method which is both easy and accurate. So let us learn one very easy method. I don't know why this method was never taught. Maybe because scientific calculators were not available at the time of Einthoven. So it's a very easy method, and by this it is not only easy, it's one of the most accurate method to find out the axis. Suppose you have the values of lead 1 and AVF. Actually, you don't have to draw anything. I'm drawing only to explain. So this is the axis of lead 1. This is the axis of AVF, and they are mutually perpendicular. So by the same method, you calculate the net vector of lead 1. So I can see in lead 1, the upward deflection is about 5 millimeter, downward deflection is about 2 millimeter. So the net vector is plus 5 minus 2, that is plus 3. Similarly, in the AVF, let's calculate. I think the upward deflection is 10 millimeter, downward deflection is 4 millimeter. And therefore, the net magnitude is plus 10 minus 4, that is plus 6. Now, by the old method, we can say that this is a normal axis because both are positive. It lies in the first quadrant. But I will find out the exact angle of the axis also, and that too in a very easy manner. You can do it mentally. I'm showing you the theory behind what I am teaching. So the magnitude of the vector here on the lead 1 is plus 3. Magnitude on the AVF is plus 6. We do not know where the vector is. That is to be found out. Let us assume this is the vector. It's an assumption. I'm not saying I'm correct. Let's assume this is the vector. If this is the vector, and if this is the angle that it is making with the zero axis, let this angle again be x. Then can we say that the measurement that we are getting, the measurement that we are obtaining on the x-axis is actually the cosine component of this. So we are actually measuring cos x. If the vector is v, then v cos x is measured here. Similarly, on the y-axis, we are measuring v sin x. Now, if the value of AVF is divided by the value of lead 1, that will be equal to sin x by cos x, that is v sin x by v cos x. That comes to tan x. So what is x? X must be equal to tan inverse or arctan of the value that you are getting, that is AVF by lead 1. It looks complicated, but see how easy it is. You don't have to do this graphical work because this is the theory behind. So what you simply do is you divide 6 by 3. So you find out arctan 6 by 3. 6 by 3 is 2. And so getting into this, I think this will be, hmm, or maybe these are not from the same person. That is why there is a confusion. These are only copied and pasted. So yeah, that is why the problem has occurred. AVF value should have been much less, as you can understand. Tan theta cannot be, yeah, it's about approximately 63. Thank you, Orpita. So that comes to about 63 degree. So is this clear to everyone how this was done? So I think this is a very easy method if you have a scientific calculator at hand. Otherwise, the second method is another easy method to practice in the clinics. So finally, after learning this, when you interpret the 12 lead ECG, you interpret in the form of rate that you must be able to do by now, the rhythm, comment on the P wave, PR interval, QRS complex. So rhythm strip is done. Comment whether the ST segment is isoelectric, interpret the properties of the T wave, comment on the duration of QT, find out the axis by any of the method, and give your final impression. So essentially, this is what we need to know in order to understand the normal ECG.